If I didn't sit in one spot, he'd nail my feet to the floor, and he's bigger than me, and I get a little nervous about that. So, all right. Now we're going to start talking about advances in cardiac care. And this is actually kind of a bigger topic than stroke. I'm going to break this up into two parts. The first part is going to be talking about some of the changes that we've made in terms of ROSC, how you run codes, how you take care of codes. The second part is going to be updates and evaluations on what we do with heart attacks. Okay. So as far as codes go, when you're taking care of a cardiac arrest, whether it is a VFib arrest, whether it's a PEA arrest, for whatever reason, and we're talking these are the sick of the sick, they aren't talking to you, they're not circulating their blood, you're doing CPR and everything else like that. You're doing all your logarithms, you're doing your great, excellent CPR, uninterrupted CPR, right? Just for the half brief second that you have to shock, and then you're right back on the chest again. You guys all know this, you're gonna see tons of videos on that one. What do we do if we actually get circulation back, right? It's kind of a neat concept. Now, if you watch the TV shows, they did a little study. About 75% of people who have a code in the hospital in TV shows, Grey's Anatomy, ER, all that stuff, by the end of the show are walking out, probably married to somebody who saved them, one of those sort of deals, and everything's great. In reality, witnessed arrests that are shockable in the hospital have about a 30 to 40% survivability. PEA arrests have about, if they're witnessed in the hospital, have about a 3 to 4%. Unwitnessed arrests that are found in PEA have about a 0.5%. Okay? So for the most part, you're dealing with dead people, which in some ways is reassuring, right? You can't make a dead person more dead. So you really can't screw it up too much more. When on a code, the first person's pulse you take is yours. You go, okay, great, they're dead. I can only go up from here, right? And then go from there. Get your team together. It's key, and we're going to do this a lot in your scenarios, but define roles. Figure out who's going to the crash cart to get the meds. Who's doing the timing. That's probably one of the most frustrating things for everybody involved is everyone's doing chest compressions and they're doing epi and everything else, and we go, how long have we been doing chest compressions? Like, I don't know, 20 minutes? 35 seconds? So have someone designated as your timekeeper, right? Because everything's basically on 2-minute increments as you go through there. Now, if you give epi a little later or a little sooner, is the world going to end? Absolutely not. But it's kind of nice if you have this nice little logarithm as you go through. Ultimately is because at the end of the day, if you're not getting them back and they're still in PEA arrest or they've gone down into asystole, you can say, look, we've checked the boxes. We've done good quality CPR. We've given them as much oxygen as we possibly can. We've done our 3 rounds of epi. This is somebody who probably doesn't have a salvageable heart anyway because they had CHF with a 20% EF before this thing started. So certainly we're not going to get them much better than that. Let's call the code. Okay. What are some ways that we can say we're done? This is always a frustrating thing, is when to say when. Because you could sit there and, especially if you've got a young medic with great big huge triceps, you could do chest compressions for like 8 days on these people. Okay. So one of the tools that we've used is using bedside ultrasound. Those of you guys that work with us in the ER see us do it all the time, right? When we stop and do our pulse checks, we'll grab our ultrasound probe, throw it on the heart, either put it on M mode or just take a look at the heart, and we're just looking for generalized contractions. And a lot of times in your PEA arrest, you'll see there's a little bit of electrical activity. There is 0 squeeze to that heart. Okay, that is a great prognosticator that you are done. Unfortunately, it's not 100%. For a while we thought it was, but then somebody down in Australia, dang it, got some people back after they had no cardiac motion, and so we can't totally rely on that. So the other thing we rely on is end-tidal CO2. So you're doing good quality CPR. Now, if you're doing really good CPR on somebody, you can keep their end-tidal CO2 above 20 for a long time, okay, because you're circulating that blood around. If you can't get their end-tidal CO2 above 20 for 10 minutes, you're pretty much finished, okay? Anything that's below 10 has a salvageability rate of almost 0. So when I get somebody that comes in from the field and the medics have done a great job running it and everything else, and we throw them up on an end-tidal CO2, and I throw a echo probe across the heart and there's no cardiac motion and my end-tidal CO2 is 7, we're done. There's not much, it's futile at that point in time. So those are tools that are really beneficial in terms of deciding when to say when. And I think sometimes, especially in an experienced group like this, you guys know what to do in a code. You guys know how to bag people. You know how to do chest compressions. You know how to put in epi. Okay? If you don't get a shockable rhythm, you just keep going until either you don't have any CO2 back, You don't have any heart motion back. Usually about 10 to 12 minutes is what I'll run most people. If I've witnessed them, if they've been down for a while, probably less. Okay, so that gives you the right to say, I'm done. If you're running this code, I highly, highly, highly recommend that you stop to all your team members and say, does anyone feel like there's anything else that we need to do? You don't want to leave any guilt in that room. And as crazy as some things people might want to throw in, let them do it. If someone says, oh, I want to add an amp of calcium, that's not the time to pull out the card and go, I'm sorry, idiot, it's not on the list. Just fine. Give them an amp of calcium gluconate. Fine. I want to give them an amp of bicarb. Have at it. You know, I want to give them 150 amiodarone. Great. That's a pretty small thing to have someone feel like, okay, my suggestion was heard, I was validated as a team member, and when we get done with this, I'm not going to walk away from this thinking, oh, if I just would have done X. And we've probably all been involved in codes where someone felt like, oh, if I just would have given the beryllium, because I learned that 25 years ago, and you're like, I don't think so. Just let them do it, okay? When you call a code, get your team together and do a little after action. Say what worked well and what didn't go well. Say, I really like the way our scribe kept time and kept us on task and gave us the 2-minute mark, the 4-minute mark, the 6-minute mark, the 8-minute mark. You know what? I opened up the crash box. I had no idea where the hell anything was. Okay, great. This is a good time to say we need to do a little bit of reorientation on where are things in the crash box. Or we only had one person that could do CPR because the rest of us have little copper bands on our arms and we have, you know, fascial problems or God only knows whatever else. We need to bring somebody else in. You know, talk about those. And then talk about emotions. Again, it's a little bit easier. You guys are all experienced. If it's the 90-year-old that has end-stage cancer that, you know, should have been DNR but wasn't DNR and you knew they were going to die. It's a totally different story when it's a 21-year-old who overdosed on heroin that has a horrible anoxic brain injury that's now coming in PEA arrest and their spouse and their 2-year-old child is sitting in the room with you. Okay, those are emotions that are really difficult. Those of you who have resuscitated young children that have had drowning victims that are 4 and 3, those are really hard to take care of. So you've got a team you're going to be working with for the rest of your career. Get them together and talk to them about what's going on. Employee health has got a lot for debriefing. We all work in unbelievably stressful environments. And I do mean this seriously. Stuff that you guys see on a daily basis is things that most other people, if they see once, talk about for the rest of their life. And you guys see it on a daily basis. And there's a little black box in the back of your head that gets filled up with all these horrible things, and you've got to find a way to let it out. And if you don't, that black box gets filled up, and that's when things start to fall apart. So make sure you turn to your colleagues and you know, the different support structures and deal with these. I think we as providers have a tendency to act like we're invincible, that it doesn't affect us, that, hey, it's part of the job. And yes, it is part of the job, but it's also part of the job to support each other and make sure that you don't have those feelings afterwards. So that's my little bit on the code. If you're fortunate enough to get them back, so these are people that, you know, the best case scenario and the most common scenario is somebody comes in, you find them, you shock them, and they're kind of comatose. This is where we start to use the hypothermic protocols. Okay, we have backed off on how aggressive those have had to be. When the first study came out 10 years ago, you had to be super militant Shia cooler, right? You had to bring them down to 32 degrees, and God forbid you got them anywhere out that. You put in your icy casts, and you had to super, super chill them. Then another study came out that said, well, really, it's not so much that you cool them, it's that you don't let them get febrile. And so we backed off on those. You now can get up to 34 degrees, so it's 34 to 36 degrees, which is where we want to keep them. For those of you on the floor and in the ER, we just throw ice packs in the groin, ice packs in the head, chill them for about 24 hours, and then wake them up and see what they do. Okay, so that's kind of one of the new things. We're not as militant about our cooling as we used to be. There is a study that just was released in the New England Journal of Medicine in the last month that said cooling does not work with children, period. Okay, so I think there's more to come on this. I don't think cooling, honestly, this is personal opinion, this is not American Heart Association or anything else like that. I don't think cooling is the panacea that we thought it was going to be. We've all read stories about kids who, you know, fall in the lake in Canada in like October, and they find them in like June, and they're like, hey, Mom, what happened over the last 6 months, right? So, you know, we know that people can survive pretty well when they're cooled. I think a lot of times the damage has been done, and then when you cool them, it probably doesn't work quite as well. And that's what the pediatric study showed. And if anybody should get benefit from it, it should be peds. So we'll see. I think as there's more studies that come out, it might just be, don't let them get a fever. It's not so important to cool them, just don't let them get a fever, because when they're febrile, they become hypermetabolic, and their oxygen demand goes up and their glucose demand goes up, and you've already got an anoxic injury to the brain. Those two don't mix too well together. So that's what we're doing with the cooling stuff. All right. Any questions on the code stuff, cooling? All right, now let's go to the MIs and things along that line and where we're going from that. Everything with your heart is basically on a spectrum, all right? On the one end, you have a STEMI, where we've completely or almost completely clotted off an artery. We have robbed the blood flow of everything downstream. The heart gets pissed off, it doesn't like it, and then eventually it can go into fibrillation. It says, to heck with you, I'm just gonna go by my own beat, and it starts going, and then everybody else starts going crazy, and that's basically what a VFib arrest is, okay? The opposite end of the spectrum is, hopefully when you were all born, you had crystal clean arteries, and everything worked beautifully, and then at about the age of 1, you had your first ho-ho or ding-dong and your McDonald's fries, and it all went to hell in a handbasket after that, and we're all on a trajectory going down to STEMIs, okay? So where you fall on the spectrum kind of tells us on what we're gonna do for you. The easiest for us as ER docs, I mean, those of you guys who worked with us in ER docs, our whole goal in life is to get the patient out of the ER. Doesn't matter how you get it. You either go out in a pine box, or you go upstairs, or you get discharged out of the, yeah, I mean, we just need to get you out of the ER. So STEMIs are our favorite. Okay? STEMIs are the massive occlusions of the arteries. You guys have all seen the EKGs of STEMIs. They're described as cowboy hats or as tombstones. It's that big elevation of the ST. Now, I'm not going to give you guys tons of physiology, but this is just kind of a little reminder. If you remember, it takes ATP and energy to recock the catapult in the heart, right? So launching a catapult is a passive thing, right? It's all that recoil stuff. Contracting of the heart is a passive thing. That's when calcium comes fluxing in and it contracts and the heart contracts. It's the repolarization, the cocking back, that takes energy. Okay, that's what happens between the S and the T portion on your EKG. It's that repolarization phase. That's the part that requires oxygen. If you deprive myocytes, heart cells, of oxygen, it takes longer for that repolarization to happen, right? It just can't get the energy because it doesn't have the oxygen. It's anaerobic and things along that line. That's why we see, instead of that brisk QRS complex, flat, and the repolarization, we see the QRS, and it just doesn't depolarize down, and it takes a long time to repolarize. That's the ST segment elevation. That's telling you those heart cells, for whatever reason, are not getting enough oxygen in there. Okay, you all know the signs and symptoms of, you know, MIs, right? Classically, the chest pain, the diaphoresis. You think about your typical obese diabetic male that comes in. That's your poster boy for, you know, heart attacks. But now we're starting to realize there's a lot of other things, you know, especially in women as well, and we're seeing this in men that we're looking even more, of non-typical signs and symptoms, right? Generalized fatigue, a little bit of indigestion, a little bit of shoulder pain. There's not a month that goes by that I'm not humbled by somebody that gives me some very mild sounding things, and I get the EKG, I'm like, damn, you're having a heart attack. That's not good. So be careful on these older folks, especially diabetics, who are chewing up their nerves. They just don't feel it the same way everybody else does. So those are the STEMIs. Something's going on downfield. Well, what do we want to do? We want to open up that blood supply. So when they come into the emergency department or they're up on the floor, there's basically 4 things that you can do. Number 1 is, you know this is a clot, and there's 2 things that make up a clot: platelets and your intrinsic things, your thrombin and all that other stuff. Makes a little net, platelets stick in there, stick out their nasty little arms and get stuck there. So we start with antiplatelet therapy, so aspirin. Pretty much in the ER, if you come in with pain from here to here, we say aspirin. Aspirin for everybody. It is by far the most effective medication that we have for heart attacks. 21 to 25% reduction in morbidity mortality, right? You talk about heparin that we give people, maybe a 2%. You talk about doing TPA, maybe 1%. Aspirin is huge. So why aren't we just standing up everywhere and having aspirin centers of excellence and everything else? Because nobody makes money on aspirin, right? We kind of think of it as an afterthought. Oh, you gave them some aspirin, good. It is truly a very, very, very important thing. Okay, so everybody gets aspirin. Who doesn't get aspirin? Who? Nope, GI bleeds, get them. Everybody gets them unless you get anaphylactic reaction to aspirin. Okay, so I will get patients all the time that will say, exactly as Danielle said, I get a GI bleed, I get a little tummy ache. Well, guess what? Your tummy's not going to ache too much if your heart stops. Okay, so we're going to give you some aspirin. Well, I'm on Coumadin. Wonderful, you still get an aspirin. Coumadin takes care of your intrinsic clotting. It has nothing to do with your platelets. We want to take out your nasty little platelets. Okay, so we're going to give you aspirin for that one. What are some other things that I hear about aspirin that they can't take? Oh, I don't know, turns my hair gray. Whatever. You give them aspirin. If you tell me that your throat swells up and you can't breathe when you take aspirin, now you have my attention, because I'm not a big fan of taking care of STEMIs and anaphylaxis at the same time. It just doesn't work too well. Okay. If you can't take aspirin, we give them Plavix. Usually load them up on 300 milligrams of Plavix. The downside of Plavix is Plavix takes about 4 hours to kind of really kick in. It's not as fast as aspirin. Okay. Now here's one of the ones that sometimes we kind of debate back and forth on. Patient says, well, I already took aspirin. How long ago? 12 hours ago. Okay, that's fine. That'll suffice. Aspirin, for the most part, sticks around for about 24 hours. And you're always replenishing your platelets. There is no data that I know of that tells you the exact golden hour of when you should do it. You're not going to really hurt patients by giving them an extra dose of aspirin unless they've already overdosed on aspirin, which happens. But for the most part, if they took it in the morning and they're in the afternoon, they've taken care of their aspirin, right? If they took it yesterday evening and they're in the next afternoon, then I would reload them with aspirin. Okay. So aspirin is very, very, very important. Probably the most important thing that we can do for them there. The other three things that we do. How many of you guys have heard about this chick named Mona that shows up for chest pain, right? Mona shows up, and I dated a girl named Mona. Whatever. But Mona stands for morphine, oxygen, nitro, and aspirin, which drives me nuts because it's the exact backwards way of doing it. But I don't know how you do AN, anyway, however you want to do it. So, yeah, exactly. Go backwards from it. So aspirin's the most important. The next one most important is going to be nitro. Okay? Nitro is a vasodilator, okay, and a mild arterial dilator. A vasodilator and a mild arterial dilator. Why am I making a huge deal out of this? While it does dilate the coronary arteries a little bit, it mostly dilates the venous side, which is why it's wonderful for people who have hypertension and flash pulmonary edema and things like that. It dilates the veins. It will dilate the arteries a little bit. Okay. How many of you have given nitrates, nitro drips and things to people who are having right-sided MIs and inferior wall MIs? Oh, come on. If you worked with me, I know you've done it, because I do it all the time. Okay. You can do it, you just have to be careful. And the reason is that the right side of the heart, if it gets stunned with an MI, it doesn't get stretched enough to contract. Remember that Starling's curve? Everyone's kind of starting to seize. They kind of remember it from nursing school way back when. Okay, and that's basically, there's a certain point where you stretch the heart that it can optimally contract back down. Now, if the heart is stunned because it's having an inferior wall MI or a right-sided MI, and you drop drop the venous pressure, it doesn't stretch. So it just sits there. So you gave a bunch of nitro, all of a sudden your inferior and superior vena cava dilate way out, your central venous pressure drops, your right side of your heart doesn't stretch, so it doesn't have the strength because it's been stunned by its MI to contract. What happens to your cardiac output? It goes straight into the toilet, okay? And if the right side doesn't pump, what happens to the left side? The left side doesn't pump. And what happens to their blood pressure? Whew, right in the toilet. So I will re-put this question to you. How many of you give nitro to a patient who gets super lightheaded and goes, whoo, and passes out and their blood pressure drops into the toilet? Hands should go up. No one? God, it's a great party trick. It's a lot of fun to do. Especially if they, they won't finish up their history and you're like, all right, fine, I'm done. Here's your nitro. Down. Anyway, if you do that, no blood, no foul, lay their head flat, give them a fluid bolus, and just go, my bad, no more nitro for you. Okay? So, it is something just to be prepared for. You guys, I'm sure, were taught every time you give a medication in the back of your head, you should be thinking, what happens or what kind of side effect can I expect? Nitro can always drop your blood pressure. It will drop it even more sometimes if you're having a right-sided MI that's dependent on filling pressure. Not always. We get tons of inferior STEMIs that we put on nitro drips and everything else, and they don't drop their pressure. But it happens commonly enough. We give them a squirt of nitro, they get all lightheaded, they get pale, down they go, you lay their head down, give them their fluid bolus, and now you know they're nitro sensitive. Okay? So to be back in the day, you show up to an emergency department, two things happen to you. You got nasal prongs up your nose and you got a finger up your backside. And then they asked you what was wrong. And you're like, I'm just here to fill my prescription. And this is the way it was. Fortunately, we are kinder and gentler. We don't do the backside thing as much anymore. And we're really getting away from the nasal prongs. Only give oxygen if you're hypoxic. So Anything less than 93%, give them oxygen. There is some thought out there, although not decent studies, that if you give somebody too much oxygen, they become hyperoxic, then they get free radicals, and those free radicals can irritate the myocardium and lead to potentially dysrhythmias and things along that line. There's some animal models for it, not some real great human models, but again, nobody likes to have nasal prongs in there, and if you're not hypoxic, you don't need to do it. The M is for Mona, and you can also say, morphine, and then Ativan can go into that. Those are for the people that are still having ongoing chest pain, or what I like to use it for is those people that are freaking out, right? You've all taken care of these patients that come in with chest pain and like, oh my God, I'm gonna die, I'm gonna die, blah, blah, blah. And what are they doing? They're bombarding their heart with sympathetic catechols, which is what you don't want to do, right? You don't want to hit your sympathetic nervous system on a heart that's deprived of oxygen because it's having a heart attack. So you can give them morphine to chill them out, or you can give them some Ativan to chill them out, try to calm them down, or you can light some incense and play a little Barry Manilow in the background and a little mood lighting. Anything you can do to help calm these folks down so their sympathetic nervous system calms down, great, happy day. About 10, 15 years ago, we used to give these people beta blockers under that same theory. Turned out that the COMMIT study, which looked at like 20,000 Chinese people, said that if you do it in the first 24 hours, a lot of them will actually go into cardiogenic shock. So that's why we wait for beta blockers about 24 hours after their MI. Don't do that as much anymore. My guess is probably in the next 10 years, what we're going to say is if you give it to people who are hyperdynamic, so those people having MIs that have the 110 heart rates and the 190 over 110 blood pressures, it probably helps. If you give a beta blocker to somebody who has a 67 heart rate and 100 over 60 blood pressure, it's probably going to hurt. Okay, so I think again, it's just choose your people wisely. So that's your STEMI. Come in the door, you get your EKG, you get definitely your aspirin, or Plavix if you need it. You get your nitro, great, put you on a nitro drip until the pain goes away, unless you get hypotensive, then we back off on it. You get your oxygen if you're hypoxic, and then you get either your morphine or Ativan if you so deem it. That's not part of the whole entire thing. And then what do? Then we give you heparin after we've taken your chest x-ray, right? Not before, because unfortunately, those of you who ever watched Three's Company and saw John Ritter, remember him? Yeah. How did he die? By an overzealous cardiologist at the UCLA Medical Center. Came in, he had the EKG findings of a STEMI. They were like, oh my God, and the lead cardiologist goes, I'm the cardiologist of the stars, thank you very much. I will be pushing at this time streptokinase and I will be saving Mr. Ritter's life. They didn't get the chest x-ray, which would have shown a very large mediastinum because he didn't realize that he had Marfan syndrome, which is where your connective tissue is crappy at best. And what he was doing was he was having an aortic dissection that was dissecting into the right coronary artery and kinking the right coronary artery closed. So yes, indeed, his heart was not getting blood, but not because it was clogged, because the dissection was dissecting back into the right coronary artery. Now you can imagine with a massive dissection of your aortic arch, what would happen if somebody gave you a clot buster? It didn't last long, okay? And I think it was like a $30 million suit afterwards. So please, 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 not that chest x-rays are 100%, but at least you can say, I looked for a dissection, aortic dissection, right? Aortic dissections are described as these horrible chest pains tearing into the back. Anytime you have chest pain plus some funky neurological symptom, you should always be thinking of a dissection. So chest pain plus my left leg doesn't work, or chest pain plus I've gone blind in an eye. That's a dissection, okay? So get your chest x-ray. If they don't have a dissection, then we give them heparin, right? We've already taken care of those nasty little platelets with our aspirin. The heparin will help thin out our blood. Take care of the intrinsic factor. If you guys go to work on anyone want to work on either coast, East or West Coast? If you do, they use Lovenox there. I trained in a Lovenox environment. I came out here, first MI I had, doing all my stuff, call up, and I started them on Lovenox. You did what? I'm like, I started them on Lovenox. We use heparin here. I'm like, oh, okay. Doesn't matter. Either one's just fine. You can reverse heparin a little bit easier than you can reverse Lovenox. Although I've asked our cardiologist when was the last time they've reversed heparin, and I get this blank stare of, well, we haven't. I'm like, then it really doesn't matter. I personally like Lovenox because it's fire and forget. It's a shot, you're done. I don't have to monitor anything. I don't have to have my nurses draw PTTs. I don't have to do any of that garbage. Lovenox, you do have to be a little bit careful if they're renally impaired, which maybe is another reason why you want to use heparin. Okay, and then from there, where do they go? Off to the cath lab. Okay, our door from the time you hit the ER until you hit the cath lab should be 90 minutes or less when the balloon is up. That is our goal. Wonderful. Woohoo! We do that here. We average about 52 minutes here. That's why we are a center of excellence for our heart stuff. Cardiologists do a great job with that one. How many folks here from Niles and Water of Elite? All right, my Niles and Water of Elite folks. Do we send them to the cath lab? No. We send them here. Well, maybe, sort of. Depends on the day and who's on and everything else like that. What do we do in Niles and Water of Elite? Instead of going to the cath lab, you get TNK. You get a clot buster, similar to what we do for strokes. Strokes are TPAs, but similar principle. Just think of it as liquid Drano for the arteries. Why do we do that? Unfortunately, we do it for the same reason we do many things in life, because the government says so. Almost all the studies that look at door to inflation of balloon use 2 hours as a marker. The government looked at that and said, that's very nice. We're going to say 90 minutes is the time for us. In order for you to be a heart center, you got to do it within 90 minutes. Is there data to support that? Absolutely not. But that's what they picked. Unfortunately, as great as our EMS crews are, on average, from Niles and Water of Elite, to get a patient from there, for them to get their aspirin, nitro, oxygen, morphine, heparin started, chest x-ray, get them into the rig, get them up here, upstairs, into the cath lab, averages about 93 minutes, which is an F, fail. You fall out, you lose your certification as a heart center for those 3 lousy minutes that we average, okay? So because of that, we give TNK in Water of Elite and Niles, all right? Now, if it was me and I was down there, I would say, to hell with your numbers. Send me up for a cath. But that's what it is. After that, you have one of 2 options. If the patient is getting better and their ST segments are improving, their chest pain is improving, whatever it was that you thought they were doing, they can go to an ICU for 24 hours and, quote unquote, cool down, which I'm not sure exactly what that means, but that's what my cardiology colleagues like to, oh, I want to cool them down. They're not literally cooling them down, they're just sitting on them for a while. And then they'll probably get a cath the next day. Or if their symptoms are worsening, so their ST segments are elevating even more, their symptoms are worse, you can go for what's called rescue PCI. Okay? That's where they go in, and despite you getting TNK, the clot busters, they will go in and do a cath on you. Okay? And we're doing more and more of that. We're getting more aggressive, which is good. These people that come in from out of the field, that are down, that have ROSC, that are unconscious, should go to the cath lab, even with a normal EKG. We don't always do it, but they should. The American Heart Association is pretty strong on that. Okay, so for Water of Elite, Niles folks, we'll give you TNK, and they may or may not emergently go to cath lab, depending on if their symptoms are getting better or not. Okay, I've had some people we give TNK to, and within 30 minutes, their EKGs are completely normalized, their chest pain is gone, they're totally happy. I've had lots of other patients that it has done zilch to. So it's just going to depend on what the patient is. Okay, and then after that, they stay in the hospital for a little while after they get stented, and then away they go. Okay. Those are STEMIs, pretty straightforward, right? Total cookbook, which is nice. Not a lot of thinking. That's what ER docs are good at, not thinking. Just give me something, give me an EKG, and off I go. Now we're going to take a step down. Now we're going to talk about all those other crazy little terms that have been batted around forever that nobody ever can seem to keep straight, or I can. The unstable anginas versus the non-STEMIs versus the, this and that and the other thing. And ultimately, at the end of the day, it really doesn't matter what you call it. These are people that are having deprivation of oxygen or blood flow where the demand outpaces the supply for whatever reason. But it isn't so severe that it has pretty much cut off all the blood flow. Okay, so the STEMIs, we've cut off pretty much everything. Okay, these non-STEMIs, these unstable anginas, these angina patients are just a case of whatever you're asking your heart to do, the blood flow can't deliver it. So the classic one, and we see it now in the wintertime, is the sedentary dude that didn't do anything all fall, is probably 60 pounds overweight, smokes cigarettes, is a diabetic, first snowfall comes in and they decide, I'm gonna go shovel. And the story is, I went out, doc, I started shoveling for about 3 minutes, and then I got all diaphoretic, I got this heaviness in my chest, and I sat down for about 4 minutes, and I got a little bit better. And then I started to do some more shoveling, and then it came back, and I sat down, and now it took 8 minutes to go away. And so what do I do? Well, of course I'm stupid. I do the same damn thing again for the 3rd time, and now, oh my God, now the chest pain's still there. And, okay, that's your angina, right? As they start revving up the stuff, the body just can't dilate those arteries enough. You get not enough blood flow to the heart. That's where your pain comes from. If you want to know what that feels like, run up the 5 flights of stairs as your thighs burn. That's kind of what the ischemia feels like. I think about that every time I run up a flight of stairs. I'm infarcting my leg muscles. What do we do for these folks? Okay, when they come in, they get the EKG. It's not a STEMI. They might have ST depressions. They might have flipped T waves. They might have, there's all sorts of different things that we see on there, but it's not a STEMI, okay? And we go, okay, that's interesting. We still give you your aspirin. If you're still having pain, we still give you your nitro. If you're hypoxic, we give you your oxygen. If you are freaking out or whatever else, we give you your morphine or Ativan. And you get your chest x-ray. If you have a super good story, we might start you on heparin right away. But usually now, what do? We send off blood work, right? Notice with the STEMIs, I didn't say anything about troponins. Never once did troponins come into the discussion with STEMIs, and they won't. Because STEMI is an EKG diagnosis. These non-STEMI, anginal, whatever you want to call them, these are going to be more lab diagnosis. We're going to be looking for dynamic changes on EKGs, and we want to know what's going to happen with these troponins. Now, troponins take about 3 to 4 hours to really start to rise in your bloodstream. So if somebody was dropping off a friend in the emergency department and all of a sudden they had chest pain, and I drew their blood right away, or those of you who are getting sick of me talking or just kind of using your Jedi forces to shut off the arteries to my heart, and someone came up and drew my blood right away, you wouldn't find any troponin. Now, if you waited 3 or 4 hours and I had heart tissue that died away, you would find my troponins would rise. This is why we do the serial troponins. Okay? After 6 hours from symptom onset, we can pretty much say with about 99% certainty, whatever it was that triggered you to do this workup didn't result from heart damage. Okay, there's all sorts of other things. Now, keep in mind, troponins are not just released by myocardial tissue. Some of the tissue going into the heart, so the inferior, superior vena cava in those areas, and the pulmonary arteries can also release troponins, which is why we see them in CHF, why they're elevated, right? And we also see them elevated in PEs and things along that line. But the troponin just tells us whatever it is that you were interested in. They had chest pain, they had weakness, they had indigestion, and you grabbed a troponin and then you grabbed it again in 3 hours and 6 hours. You're just asking yourself, is that going up and is that demonstrating any heart damage? Okay. If it does go up, you can say that these people had a non-STEMI. Okay. In which case, at some point in time, they'll probably be CAF, they'll be started on heparin, and we'll watch them and do everything else with that one. A lot of those are going to be, medications and diet modifications, things along that line, ACE inhibitors, beta blockers, things along that line. If they don't go up, which is very common, right? You guys are treading tropes all the time, they don't go up. Does that tell you that you're disease-free? Absolutely not. And this is a critical point because I hear patients say this all the time, not because you guys are saying it, but they misunderstand it. I was here in your chest pain unit, and I was ruled out, I don't have any heart disease. Oh, no, doughboy, you probably do have heart disease. You just didn't cause any damage to your heart. Big difference. That's where the stress tests come in, okay? None of our stress tests are 100% accurate. At best, you're looking at about a 90% accuracy. And what we do, whether we do a chemical stress test or stress echo or a treadmill stress, is that we put your heart in a position where it's working harder than it should, and we see what happens to it. So on a treadmill stress, we see, do your EKGs change? On a stress echo, do we see, are there areas of your heart that aren't moving normally? Nuclear stress, are there areas that aren't taking the dye uptake the same way? All those stress tests kind of tell us if there's a problem in there. And then from there, you can go on and do a CAF. Okay, so that's what those stress tests do. So ruling somebody out just says the pain, the indigestion, the fatigue didn't cause heart damage. You need a stress test or some sort of provocative test or a modification. Okay. Everyone kind of cool in the non-STEMIs, and that's where the blood tests come in. Then we've got the group that are really, really low risk. These are the 22-year-olds that come in, that are panicking, that are like, oh my God, it hurts right here when I do this, and this is hurting me right now. And you're like, just stop it, then don't do that, It seems pretty straightforward to me, but, these are your costochondritises, or, you'll get the patients that come in that say, oh, I've got a bad cold, and every time I cough, it hurts right here. I think I'm having a heart attack because I have this brief half second of pain. No, you're not. Okay, a lot of those people we use just screening EKGs on, right? EKGs are about 65 to 70% sensitive. Okay, that's not great, right? You're gonna get 7 out of 10. I'll tell you, if I missed 3 out of my 10 heart attacks, I would be in court all the time. So we use it for people that we have a very low pre-test probability. You've got somebody that comes in that you think, I don't think you really have anything in your heart, but I'm just gonna kind of put a little icing on the cake. I'm gonna get an EKG. We do that all the time. I had a little 12-year-old last night when I was working at Waterville that her mom, not the sharpest knife in the drawer, was convinced she was having a heart attack. Okay, she was not having a heart attack. She didn't want to go to school today. Fine. So I did an EKG and I showed the mom, look, it's perfectly normal. She's not having a heart attack, all right? My pretest probability of her having a heart attack at 12 was 0. So I can use an EKG as a nice little teaching point for mom to make her feel a little bit better. And we do that all the time with EKGs, okay? That's the heart stuff. Any questions on what we do, why we do, and everything else? You guys are now experts. Go forth and save lives. Thank you.